we're live.
Perfect. Well, welcome everyone to another Patient Scene podcast here on Blab Live. And you know what? I am not even going to try to pronounce your name because we were just talking before you hopped on if it's Sumit or Sumit. And my autocorrect put Summer. So obviously Siri's racist somehow, I think. But how would you pronounce your name the correct way?
It's Sumit. And I appreciate you guys being concerned about that. That's very thoughtful of you.
Well, as I tell people, I taught English overseas for a couple of years, and nothing is going to confuse you more than trying to teach it and get asked all the questions you never thought through and go, this is a really messed up language. So thank you so much for joining. And Andy, please introduce why we have such a special guest today.
Yeah, so I'm super excited that we've got Sumit on the Blab this evening. From my perspective, he's a young physician. He's very invigorated. He's definitely leading the conversation and part of the charge. And what we've been able to exchange is really about sort of making sure that, you know, the patient experience and the patient focus and really getting back to that natural relationship between patients and physicians. So I'm super pumped that we've got Sumit with us this evening. So from that, would you like to introduce yourself to the rest of the world?
Yeah. First of all, I want to say I'm really honored to be on this chat, on this podcast and Blab. It's the coolest thing I've done since becoming a doctor. And that might sound crazy, but I really mean it. I appreciate you guys having me on. I just consider myself, like you said, a young physician in the United States who's trying to learn how to be a good physician. And the way that I started to follow you, Andy, is someone recommended that I join Twitter about a year and a half ago, mainly to learn about clinical knowledge. There's actually a growing community of healthcare professionals of all kinds and types that obviously you're aware of more than I am, that was using Twitter to engage in sharing clinical information and all sorts of connections that way. And while I was getting involved in that, I stumbled upon this entire community and different communities all around the world. And it just opened my eyes to seeing other people that see that there are issues and that we should be striving to make them better. And I think one thing Andy has always said, and I think he said it recently on the Patient Scene, is that he's not really satisfied with the answer that that's how it's always been done. And I think that's something that young trainees like myself, sometimes we get that impression a lot because it might be shocking to you, but a lot of the way that we train and kind of educate physicians, nurses, nurse practitioners, physician assistants, we are kind of in this older mindset. And as you recently discussed on a recent lab, we're in a different kind of world now. It's not the industrial revolution anymore. It's the connection revolution, and just the world is a different place. And I think, unfortunately, healthcare lags. And so that's why I'm excited to be here and excited to learn from you guys and follow and be involved. And I think the most important thing is a conversation, because once you have a conversation, then you can share ideas and work towards change. So anyway, I'm really excited to be here. For those of you that don't know, just a quick one-liner, I'm an emergency medicine resident physician in Baltimore, Maryland. I'm from New York City originally. I kind of knew that I wanted to be a doctor growing up. I went to college in upstate New York. Actually, I think we've heard upstate New York mentioned a little bit. I was in Binghamton, New York, not far from where Andy was recently for his conference. And then I went to Temple University in Philadelphia. Now I'm in Baltimore. So I'm just really thrilled to be here. Thanks for having me, guys.
Awesome.
Thank you.
Thank you. So my first question really is, what, in your perspective as someone who's going through the process of becoming a physician in your residency, what's one of the things that's lacking in the patient experience, especially in the emergency room where it's just nothing but chaotic chaos all the time? How is that patient experience missing, or what's going on? I mean, from your training that's still fresh in your mind, was that even a part of the medical school experience, is basically treating people like people?
I think that that's a great question. And I think I'm going to think about it in terms of two questions. One is my current training right now as a resident physician. And the second question is more towards medical school before I got to residency. I'll answer about residency right now. I've been doing this for 10 months and I'd had experiences with my own family, as I'm sure most of you have had, and our viewers and listeners, going to an emergency department, no matter where you are. And one thing that I definitely recognized is that in pretty much any emergency department, the patient experience is extremely difficult to even address in that chaotic environment, with the number of patients that are in the waiting room, with the kind of clinical issues that I am and my colleagues are working with and trying to take care of people. I think it is very easy to lose sight of the patient experience, in things in terms of how patients are addressed, how the triage process works when you show up in an emergency department, how are you communicated with, how does someone get your information, how do we even decide who needs to get seen first? I mean, obviously emergencies we do see immediately, but if you have vital signs which are not concerning and you don't appear extremely ill, chances are, depending on where you are, you're going to end up waiting quite a bit. And that experience in and of itself, waiting. A lot of times our patients, especially in inner city Baltimore, sometimes I've seen wait hours of 36 hours. People have waited an entire day and a half. I mean, this is while we've been living our life. I've been in the emergency department working. Other people have gone to work, gone home, and they're still in the waiting room. And I think that the patient experience it's lacking. I mean, you asked what was lacking, and I think that we don't focus on the patient experience. And that's why I think I latched onto what I'm hearing and what I'm getting involved in, because I think that discussion is something we don't have. I mean, you'll see articles and you'll listen to different people talk about patient satisfaction. And I don't think that that's what we're discussing. I don't think we want patients to give us good reviews. That's what patient satisfaction kind of sounds like. And patient experience is about, how does the patient feel? Do they feel like they're being cared for? Do they feel like, as Andy, you always mention, are they the beginning and the end of healthcare? And I think that that's what I struggle with. And when I'm in the emergency department myself, I try, when I see a patient, to make sure I sit down. I don't have any electronics with me. I try and make eye contact. A lot of the things that I've been hearing and seeing and discussing, fortunately, I've been taught. And I think that's what we're trying to stress more. But it's very challenging given the limited resources and the environment. And then going towards medical school, I actually plan to write something in the near future when I have some time. I actually plan to break down what my medical school curriculum at Temple University School of Medicine was. Because I think not many people who are not involved in healthcare actually know what a physician curriculum looks like. And I think a lot of the things that we imagine and we kind of expect and we hope and pray physicians are being taught and are learning, it's not actually in the curriculum, or it's not emphasized in the way that we would like. For example, medicine traditionally is silos. Doctors train with doctors. Doctors lecture doctors. It's kind of this it's basically, hand-me-down education from one generation to the next. And the world doesn't learn that way anymore. I was appalled when I got to medical school to find that there was very little collaboration in curriculum design, in discussing these types of issues among different healthcare providers. Even people that work every day together in the hospital spent very little time together in their training. So I'm talking about nurses, I'm talking about physician assistants, nurse practitioners, patient care technicians, nurses, aides. All of these people work together on a daily basis, and in a very weird way, in a kind of strange system, we spend more time apart in our particular educating environments. And then someone actually puts us in the hospital and says, go forth and learn how to work together. And we spend so much time trying to just learn how to work with other people in the hospital, that we have no time to focus on how we can make the patient experience better. And I think that's something that I've seen myself, is that the curriculum doesn't focus on the things I wish it did. Also, and this is kind of what this is all about, hospitals, physician offices, a lot of them are not laid out or organized, designed to put the patient experience first. They're kind of designed for billing purposes, for ease of limited resources. Sometimes we use office designs and emergency department designs that a CEO or some kind of higher up felt would be cost effective. And in the end, it's not, because it affects our efficiency and ultimately it hinders the patient experience. So I could go on and on about it, but I think that the patient experience is lacking. And that's kind of why I'm inspired to be involved in these discussions and try and get other people involved as well.
So one of the questions that I have is, based on kind of where you are in sort of your progress from medical school into residency, and especially with the specialty being in the ED, outside of your curriculum and your training, you're, probably very sociable, you learn very differently. And so I guess the question that I have is, do you see a huge discrepancy between the way that you're sort of taught and that you go about being educated inside of medicine versus the rest of your daily life?
Yeah, and I think that's a very important question for any physician who's learning to answer. And the truth is, I realized pretty early on in medical school that becoming a physician is a very demanding profession and career, because I'm always learning. And sometimes we lose sight of that a physician doesn't really stop training, because every patient encounter, every time we speak with a nurse, every time we work with someone, doesn't matter if we're our first day or if we're 30 years in, is always a learning experience for us as well. So I think it's a continuing process and it's a moving target. And I think we learn differently today. And the people that are innovative in medical education and kind of the leaders are definitely working to address that, because traditionally medicine was taught in big lecture halls. 200, 300 medical students would be, basically taught that, and they would take notes and they would be expected to go read this book, thousands of pages of information, and rotations were pretty much structured the same way over the years. And things have changed quite a bit. We're trying to incorporate different types of learning. There's a lot of emphasis now, especially for residents like myself, learning outside of a lecture environment. And we're trying to, I think it's not going to go away, but I think the way that lectures are used and the way we're taught is changing. But to answer your question, I think being involved in healthcare social media is actually one of the ways that I am educating myself, because I find myself exposed to things that I'm not hearing about in my lectures. We're really good at teaching doctors about clinical knowledge. We're really good at teaching doctors how to apply their knowledge of disease. What we do understand, they're very good at applying it. Where we struggle, and where I think the challenges lay for healthcare, is bringing that physician patient and not just physician, obviously, but the nurse patient, the physician assistant patient, the nurse practitioner patient relationship. The people who are caring, the people that are being cared for, I think are not the emphasis of healthcare right now. I think there's many different things that are being discussed. And I think marketing and big pharmaceutical companies, and obviously the business of healthcare is a part of it. I think that it's changing. I think the way we learn and the way I learn, I'm realizing, is evolving as well.
Yeah, no, that's great. Go ahead, AJ.
Oh, sorry. You said something when you first started that I thought was really interesting. And you said very nonchalantly that when you meet with patients, you're putting your electronic devices away, which, as we talk about all of the dings that we've heard or distractions every day, or even just doing this blab, They're just part of our normal life. So what, as someone who's definitely has grown up with the internet and all of the distractions, what made you make the decision to consciously put devices away so you weren't distracted during that patient time? Because it's so easy not to.
Right. I think as kind of an aside, just to give some background, I think in the emergency department we have an opportunity to really be mindful about that because I don't get paged. I'm in the emergency department. If anyone needs me, they know where I am. Usually I'm the one trying to reach other people. So emergency physicians and people who are working in emergency department have a real opportunity when they go into a patient room to really focus on that patient. And I actually credit the people that have trained me over the years. It goes way back to when I actually volunteered in an emergency department. I saw physicians years ago, even when they went into rooms, sit down, put away their pagers. And I think it's also partly, I do realize that technology is so much around us. I think when people feel that you are interested in them and you look them in the eye and you ask them why they're in the emergency department, what's going on, what's bothering them, it gives you a chance to really connect with someone. And I was definitely taught early that that's a big part of what I do. It takes a lot of courage in many ways to go to the emergency department or go to a doctor or go to any kind of professional and say, I need help. And I imagine a lot of it has to do with what I would want someone to do for me. And to be honest, I've been on the patient side. I've been with loved ones in the emergency department. I've been in offices alongside a loved one who's getting taken care of. And I think that that adds a layer of perspective to what I do, because when I walk into a patient's room in an emergency department, I kind of know that this is a difficult time or difficult moment for them. And in the end, I think that we are training doctors to be mindful of the patient, but we're not sort of extending it beyond our just one-on-one communication. It would be a lot better if I could go into a room that was designed with the patient's experience in mind, whether it's things from what's in the room, what signs do we have in the room. I mean, I don't want to walk to an emergency department room that has all these big signs and things that don't really apply to me. It might be for healthcare professionals, like reminding me to sanitize my hands or wash my hands before I walk out. That doesn't really add value to the patient experience. It's kind of more as a reminder to me and the kind of curtains that we use. And I'll give you one thing that I hate. I hate walking into a patient's room and not having privacy. In a lot of emergency departments, patients are in multiple patients are in rooms. And so it's frustrating. I mean, I'm violating HIPAA every time I walk into someone's room and someone else, another patient happens to be in their room in a different bed, separated only by a curtain. And I mean, it's kind of silly that we make an emphasis on our technology and how we communicate regarding patient data and HIPAA. And it's not unique to one hospital. I mean, I'm sure if we asked people, they would say, oh yeah, now that I think about it, I've been in an emergency department where I was in a room with someone else, sometimes as many as 3 other patients. And I don't think we do that intentionally, but it shows a disconnect in designing that experience. No one wants to be one of 4 people in a room, and let alone the privacy issues that I brought up. So anyway, I'm digressing beyond I'm definitely, as you can tell, I love talking. So this is
no, I think that's a fantastic point, because with a lot of the work that I've done at Mayo Clinic, it's around the Center for Innovation, and it's all about designing the experience that transforms health and healthcare. So what you're talking about is right up my love language of saying, okay, how do we design better? And, it struck me, I didn't even think that that's a HIPAA violation, sitting there with a sheet between you and another patient. Just saying that this is something so unique that we're not even thinking the design. And I ran into the emergency room a few months back as I thought I was potentially having a heart attack, just turned to be interwall chest pain because of the way I slept the night before. But looking at, when you're talking about the room, I'm thinking all the signs in there were for the physicians. Hey, don't forget to wash your hands. Hey, use this remote for the TV. Hey, do this. Hey, this is for that. So everything designed in it was not for me. but for them. And there's a tipping point of where it's for efficiency for the doctors and nurses to do their jobs. But at the same time, like you're saying, the emergency room is an incredibly scary place for someone to be. And how do you create it to be a more welcoming environment? Because a lot of people don't want to be there.
Right. I definitely have some thoughts.
I guess that was an open-ended question.
Yeah, I definitely have some thoughts. I don't know, Andy, if you have any thoughts or if you want to ask anything before I continue.
So I'll let you continue, and then I may interject because what I want to interject, I think, will sort of flow with it. So go ahead.
I just want to.
Andy has a few thoughts too. So.
Okay. I really want to, emphasize I'm here to learn from you. So I don't want this to feel like it's about me as a guest or anything. I mean, this is amazing, and I hope we can do this more. And I look forward to learning more from these podcasts. I mean, ideally, I would love to share these with other medical professionals. I think they really need to hear what we're talking about. I've been to emergency departments through my training. Just to give you some background, I've had to, as a volunteer, as a medical student, as an EMT before I started medical school, and a paramedic, and then in residency, I've probably been to 20, 25 different emergency departments over the past 10, 12 years. And every single one is different. And there have definitely been some standout emergency departments. I can recall one actually located in the northeastern United States, in Massachusetts, which every patient got their own room. They consciously designed the emergency department so that they had 100 beds. But what they did, which was, I think, fantastic design, is they separated the beds in little groups. So they put 30, 40, 30 in these big areas. They put one patient in each room. Now, sometimes when they get busy, they do have to place patients in the hallway. But for the most part, they were able to maintain patient privacy. I think that as a patient in those emergency departments, it was easier to make them feel like they were the focus, because when I walked into that room, they had a spacious room, and it was very sleek, very simple design, pleasant colors, and not a lot of signage or placards. And again, by separating out those 30 beds instead of putting all 100 beds in one kind of open space, it limited the noise, the sounds, the smells, the sights, and it kind of things like that, I think, are where, obviously I don't know a lot about design, but that department stood out to me. And obviously in inner city areas, we deal with limited space is a big issue. That's why rooms do have multiple patients. So I think it's an issue that I hope when we do things like redesign these departments that we keep in mind. But anyway, Andy, what was your thought that you wanted to interject?
So actually, two thoughts. So one actually has to do with the last comment that you just made. So you've been able to go through a couple of different EDs in sort of your experience, and you sort of mentioned, hey, some are really good, some aren't so good. The ones that are really good, do you feel that you could basically take that and sort of put that into any other hospital or ED as a redesign, and then it would just be magic and it would work? Or do you think that there would be slight differences based on the communities and the populations in which those EDs reside, so you'd have to make some modifications?
I think that's a great question. I think a lot of the ones that I tend to reflect on as being better than other emergency departments, they tended to have space as something that they had as a resource. So it's harder when you have a hospital in the middle of a big city to focus on a lot of these design aspects. So I would say one thing I've noticed is that space is a big limiting factor. I think where there is space, those people that make these decisions have more flexibility. Now, that being said, I've seen some bigger places that are not designed that way. You would think that they would be, but they're not. So I think I can generally come up with probably kind of a layout or a schematic for what I would think as a physician, but also as having been a patient and been with patients as their loved one, what I would envision is kind of, I guess, an ideal, or my idea of an ideal emergency department. But then the caveat is that in some places, such as the big cities in the Northeast, where we have a lot more density of population and we see a lot more patients, we have a higher volume. Those types of things do mean that we need to make adjustments. I don't think we could make all emergency departments everywhere have the exact same appearance, but I think that there are things that we can do that will make them generally have more of a consistent, better patient experience. And that brings me to one thing that I've noticed over the years is that the decisions behind this, and Andy, you probably know a lot about this, and also you, AJ, because you've helped redesign things and facilities and build them from scratch. I find that I'm not ever involved, not just me, but even people like me who have been in their field for 10 years, 15 years, are generally not involved in these decisions, which always baffled me, because obviously we want to put the patient experience first. But I think physicians, nurses, nurse practitioners, PAs, techs, custodial staff, I mean, everyone works in this environment. Everyone sees what patients have to go through. And I think our opinions are important to take into account. And I mean, it's kind of shocking, but no one ever asked me what I would like my experience with my patients to be. Usually I just show up and someone else has put all of that together, and they kind of say, here, this is what you have. This is what you're going to work with. And I would love to see that change a little bit, because I think it's an opportunity for the people that care to engage with those that are cared for, because they're kind of the heart of what we're doing.
Yeah. So Janet from Get Social Health, she actually has a question for us. So she wants to know, do you have a chief experience officer at your hospital?
If we do, I don't know about him or her. So it's quite possible that we do. But as you can see, someone like me who's pretty much at the hospital every other day or every day, taking care of patients, is not aware if they exist, or if they do, who they are. So I think that's a really good point, because if we don't have one, we should. And if we do, they're not involving us or not letting us know.
So yeah, I'd like to ask, maybe Janet can hop on a little bit, because I'd like to know what a chief experience officer does. What kind of a role is that? Because it sounds a little cushy of a job, I guess, but we have so many C-level positions coming out with chief innovation officer, chief mobility officer, every different technology that's coming out, we have a new C-level. So as a chief experience officer, is that just kind of like the Disney exec that knows how to make sure everybody's happy and having the best experience possible? I mean, that's what I would assume, but what does that really mean?
Hey guys, can you hear me okay?
We can.
Yeah, absolutely. Loud and clear.
Hey, hi, nice to see you all. So the chief experience officer, I have yet to actually meet one personally, or even link into one in LinkedIn. However, you are absolutely right, AJ, that a lot of these people are coming out of not just Disney, they're coming out of hospitality. People who have for years in the Hiltons and the W's and the fancy hotels have figured out how primo it is to have that connection with with their customers and translating that experience. Now, where they ought to be is walking the floor, but it could be that they're just so new, they're not there yet.
Yeah, it's actually interesting, because last week I actually had a conversation with a major academic medical center, and it happened to be in regards with sort of their chief medical officer for one of their service lines. and then also their chief patient experience officer. And in the conversation, what I found very interesting is that the two weren't connected. So they were trying to focus on the service line and redesign it, but fundamentally the way that they were going about redesigning was completely different. And so what I tried to do was, kind of talk to them from my perspective to get them to be aligned around the same methodology of going about and doing it. And so a prime example was as the CMO, the medical officer, they were thinking about it from a clinical workflow perspective and from a distribution model. So they were thinking, hey, how do we create a hub and spoke? How do we make sure that we get access improved while we're getting the quality of care that we want sort of at the hub? And then how do we distribute? Yes.
Sorry, I'm gonna take care. We got both kids tag teaming the stream in right now, so I'm gonna listen to the rest of this. And Sumit, I definitely want to connect after this to talk more about your passion for design. So thank you so much. It was great to meet you.
Thanks, AJ.
You as well, AJ. Good luck.
Good night.
Good night.
So this is called tag team blabbing.
That's right. And what was interesting is that, so in the hub and spoke and kind of thinking in terms of the clinical workflow, as the patient experience was talking about it, they were talking in terms of almost the physical appearance. And so what I tried to educate both of them on is that they needed to take an ethnographic research perspective and actually fundamentally understand the people in those communities that they were serving and sort of map their experience. And once you map their experience and you understand the language, the channels, the barriers, even the financial aspects to it, that you can start to take clinical workflow, you can start to take physician workflow, nurses workflow, you can start to take all of these things and layer it on top. And by doing that, you start to see where things are coordinated and work very well. And then you get to see the pockets or the areas that have some bumps or some seams. And those are the areas that they really need to focus in on.
Okay, I'm trying to wrap my head around this, and it almost sounds too complicated because every single person is an individual. So every single person's experience is different. So I'm not quite sure how a process works when you have so many different types of experience.
So you're right. Every person's experience is different. And so from my perspective, fundamentally, I think there's kind of two different buckets. There's patient experience, which is sort of this large, broad category that, hey, we think of design, we think of workflows, we think of, the physical layouts. We think about the different interactions. But then there's another category where it's around my ideal patient experience. And that's about what is the experience for me at the N of 1. And I think that's where it becomes kind of, as Sumit, you were talking about before, is what is that personal connection? What is the area that I have in order to have a private dialogue between myself and my patient? How do I make sure that the patient, once I'm done in sort of having my encounter with, that there's a smooth handoff with either a nurse or triage or maybe the next step in the journey. But on the front end, when you actually go to say, hey, I've got some space and I want to redesign this, or I want to, build something that's never been there, you kind of have to roll up your sleeves and you need to understand the population that you're serving. And while you can't interview and understand every single person, what you can do is you can start to understand the different groups of people and a large majority of their access issues or their challenges. And then what you try to do is you try and create multiple channels that then allows people to access the care that they want to via the channel that's the most comfortable to them. Does that help a little bit?
Absolutely.
Absolutely. So Sumit, I don't know from your perspective if you've got, any additional thoughts in terms of kind of what I just said.
I think it definitely makes sense. I think it's a common concern. Even I also was wondering, at different points, how do we make the experience better for everyone when everyone is so different? I mean, we see patients all the time that everyone kind of has a different emphasis, and I definitely can understand Janet's question. I thought it was a very appropriate question, and I thought your answer made a lot of sense to me. I think that what we're basically trying to do is connect our patients' needs, their backgrounds, and these are things that we try really to do, but it's difficult when the systems we use, for example, so I can think of many opportunities in healthcare, the way that patients interface with, especially their longitudinal care providers, their primary care doctor, their nurse practitioner, physician assistant, their physician that they see in the office setting. I think the way that interaction happens, I guess healthcare used to be you had a doctor who took care of an entire town of patients. They were the doctor for the kids. They delivered the babies. They went to someone's house when they got sick. If someone got a cut, they had an accident, they would show up at the doctor's door. The doctor would stitch them up, take care of them, do what had to be done. And that's kind of where I guess healthcare was at a time. And my dad is actually a primary care doctor in New York City. And his experience, I've seen it change so much. Even 20 years ago when he was earlier in his career, the way that he could interact with his patients was very different. To be honest, there wasn't as much paperwork. I think that we've come a long way in terms of safety and our treatments and knowledge. Obviously, we're doing research all the time. That's all important. So a lot of it is important. But it's also added more barriers between a physician or whoever's giving care and the person receiving it. And I've seen how his experience has changed to now where he doesn't have his own private practice anymore. He works for a hospital. He sees his patients in their facility. And so whereas the doctor used to be able to kind of make their environment, take the environment to the patient, which is, I think it's phenomenal. And I kind of wish medicine was practiced that way.
Well, it's going back to that, right? It's concierge medicine. In North Carolina, we actually have a practice that is doing house calls. Oh, heck, what's it called? They advertise on NPR all the time. But it's basically house calls. And they do it a lot with the physician's assistants are doing that. So they're back on the road. Right. And hey, telemedicine, we're doing a lot of things. It isn't necessarily quite as personal as a home visit, but I don't really want the doctor to come see my house because if I'm sick, my house is a wreck.
Right. Yeah. And I think you're absolutely right. I think everyone recognizes that. And there's a lot of opportunities using these things. One thing I love about concierge medicine is that it kind of eliminates the middle people. It's a physician or someone who's giving care, a nurse practitioner, physician assistant, coming up with their terms, their own prices, their own structures for how they're going to deliver care, their own benefits. And a patient will look at that and say, okay, this makes sense for me and my family, that I would spend this and get these benefits. And, you deal directly with the person taking care of you. I've heard from people that are doing it this way that they absolutely love it because they're able to really focus on the people that they're taking care of. They might have a practice of 1,000, 2,000 patients, but they really get to know them very well. They're available 24/7, 365. And sometimes I ask them, well, how about vacation? And how about, spending time with your family? And they bring up a really good point, which is when medicine is delivered that way, it becomes less of an issue. They don't need to worry about vacation. They don't have to worry about spending time with their family because they're doing it. It's a beautiful blend of I guess what a doctor's experience I imagined or I hoped, or maybe one day I wish I could participate in, where it's kind of just a part of who you are. I mean, it is a part of who I am. They're around me all the time. I can't never not be a doctor. It's just not not something that I have an option of doing now, for better or worse. And so I think that concierge medicine, telemedicine, I think those are very interesting opportunities. Obviously, pricing, I don't know about it. I don't know a lot about finances. I don't know if concierge medicine is actually saving patients money. I would hate for someone to pay for health insurance and have to pay a concierge physician. That doesn't make sense to me.
No, usually there is no insurance involved. That's part of the concierge issue is you're paying, in some cases, if it's truly concierge, you might be paying quite a sum annually for 24/7 access. And a lot of people who are picking up on that are, executives who do a lot of world travel and can't make a regular schedule, or startups. We have a physician here. Her practice is called Unorthodox. And she deals predominantly with startups, with young folks who aren't really making a commitment to healthcare, but need to because they're working insane hours and they're exhausted. So it's interesting how these different styles of practice are developing. And then concierge, there is also direct pay, which is where a lot of physicians are going because they just don't want to deal with all that insurance middleman. And the copay or the pay you pay is about what your copay used to be. So, and then they're cutting out all that extra paperwork, and it saves so much time for the small practice that it actually does make sense. So that's what we see happening here. There are a lot of physicians who got, as your dad did, caught up in being hospitalists who said, I want to go back to private practice. And so they're creating smaller practices that are direct pay.
Yeah. And to that point, I've got sort of two questions. So the first question is Sumit, from your perspective, or even kind of being an observer of your father's, do you feel that there's a pressure to meet a productivity number or to make sure that, you're seeing the right number of patients? And if not, like what do you feel is that pressure, that expectation that's placed on you due to that?
Yeah, absolutely. And you just gave me a great idea. I think it would be great to actually involve my dad at some point. He's obviously an older, more experienced physician. He's learning about technology. I'm proud of him. He's finally using an iPhone and getting involved. But I think hearing from him firsthand might be something we want to do at some point just to get a different perspective. Obviously, I'm 10 months in. He's 30 years in. So it's going to be a different kind of discussion you can have with him. But I would say I've heard from him over the past 10 years or so since he gave up private practice. And now his setup is that he works in an office that is part of kind of an outpatient center. And what's interesting is that he's the only primary care doctor in that office. And it didn't start out that way. Now it is full of specialists and surgeons. And he's the only primary care doctor that's left. And the only reason, there are a lot of reasons, but I think a part of it has to do with his productivity and his relationship with his patients. He brought a lot of his patients from his private practice into this practice, which I think is the financial reason why hospitals did all this. Obviously, patients flow into this hospital center now, this hospital network. But he has multiple times discussed with me how there is pressure on him to see a certain number of patients, and their primary care doctors are always overbooked now. There is no way for them to really emphasize that personal relationship with their patient because in many settings, they're seeing 30, 40 patients in a 10-hour day. And that's just not going to allow you to really connect with someone. We know all the time, we hear stories of people that went to see their primary care doctor and they might have diabetes, hypertension, high cholesterol. They might have had heart disease. They are on maybe 15 medications. They may have gone to the emergency department a couple of weeks ago because they didn't feel well and they got discharged. Everything seemed okay. They're going in to see their primary care doctor. And guess what? They have 15 minutes with that doctor or that nurse practitioner or PA. And in that 15 minutes, they are expected to talk to them about their chronic illnesses, talk to them about their ED visit, go over their medications, and obviously ask them how they are feeling as a person. what's going on in their life? What are the issues that are affecting their health? Is there increased stress in their family life or their social life? Are they dealing with financial burdens? All that I just mentioned could take an hour or more. You could spend as much time as you had with a patient. And my dad's doing that. We're trying to do that in 15 minutes, 20 minutes, 30 minutes with patients. And it's really challenging. And I know that some of the best days for him are the days where he actually says that he had cancellations and he actually had time with patients that he wishes he would have on a regular basis. And I think it's very sad, and it speaks to the culture in healthcare and the environment in healthcare that we have doctors who are excited when they have cancellations because it means they can spend the time they want to spend with their patients that are there. And to have a system where that is when a doctor gets excited is quite frankly kind of pitiful, for the kind of country we live in and the access to resources we have. It blows my mind. Absolutely blows my mind.
Yeah. So first of all, it blows my mind as well. And I think from my perspective, one of the big things is, as I have mentioned before, it's kind of, we've industrialized medicine. We've made it this industrial complex in which, physicians, nurses, other allied health professionals, they're basically being asked to create widgets versus actually being able to take the time and have meaningful dialogues and connections with their patients. And, as we look at telehealth, as we look at telemedicine, as we look at concierge medicine, it starts to make me at least question or challenge, is this going to be the disruption or part of the disruption that happens when all of us, as we start to get into our older years, that our expectations of what we want from healthcare and from our physicians, will they change? And because those expectations change, will that force kind of healthcare to change as well? I don't know if you've got any thoughts, or Janet, if you've got any opinions on that.
I'm actually looking at this awesome website for Oak Street Health, which is a Medicare practice, and it looks like they've got everything all in one place. Very cool. Thanks for sharing that, Care Radio. I think that is very cool. So sorry, I was distracted.
No problem. Sumit, do you have any?
Yeah, I think that there's a natural sort of change that is going to happen among healthcare providers in terms of how we connect to our patients, because we are different. I am on my phone quite frequently. The way I learn is through a lot of digital media. And I deal with the same kinds of issues that my patients deal with sometimes we need to put our technology down. I mean, this is great what we're doing right now, but it's kind of an appropriate use of that technology. It would make sense if I went into a patient's room and I was doing this. It doesn't make sense. That's not the time or place for it. And I think it is changing. I can tell you that my experience personally has been that healthcare, especially medical education and training, lags so far behind the rest of society. I think you mentioned it in a recent blab here on Patient Scene that other industries have already revolutionized themselves multiple times over and changed drastically. Entire industries have gone away and new ones have come up in their place, and then those have gone away and then they were replaced. But meanwhile, healthcare is this kind of lagging, part of the group that just seems far behind. But I think that it is going to change, but I don't want to wait around for natural change. I don't want to wait around for when my kids are in this situation. I mean, if my kids were alive and they were having to deal with healthcare the way it is right now, or they would have to grow up in this system, I would feel I let them down. And I don't want that to be the case. And I don't think any of us really want that, but I think sometimes people feel that there isn't a choice. And there is. And I think that's what I just bring it back to patient scene and my ideal patient experience and what you've been discussing and your recent post today. We do have a choice, and we all have a choice. The things that patients are expecting when they go to see their physician, that matters a lot. The more that patients are given an opportunity to voice their concerns, it's part of the reason why I love the healthcare community on Twitter, is because it connects me with patients and their experience, and we don't involve patients enough in these decisions and designing healthcare, and that's going to change. But I don't want to wait around for it. I don't want the next 50 years to go by and we are still kind of lagging behind who knows in 50 years, the way the world is changing, what the world would look like. And the challenges that we're going to face as, just human beings in general is going to be very different in 50 years. And I think that it's natural that younger physicians, nurses, nurse practitioners, everyone who's kind of delivering care, they are learning differently. And we are also different than our predecessors and who we are taught from. And I think that that's good, because if everyone learned the same thing, we would never progress. So, I mean, my dad never did this as a physician. He never talked about the patient experience. With me, he did, but he never talked about it with his patients. He never, think about healthcare social media. That didn't exist. And now it does. And now more and more physicians and nurse practitioners, PAs, everyone's getting involved and realizing that, we can actually use this, and we can use it in ways that we never thought possible, where I'm connected with not only patients and patient advocates, but also people who want to revolutionize healthcare. And there are plenty of people that have power that are involved on healthcare, social media, and that's just kind of a small part of it, it keeps going. So things will change, but I don't want to wait around for it to happen at whatever pace it is, because it's not fast enough.
Yeah, and that's that's just my nature of how I am. I'm not very patient, which is good and bad at times. I think, especially when it comes to, patient experience, the status quo, and really connecting the different groups inside of healthcare, that's really fundamentally where I'm trying to focus and accelerate. And sometimes it is, a little bit of, being provocative and sort of poking the bear and kind of doing things that sort of raise that or bring that conversation to the forefront. So, I definitely think that it's good that we're all, kind of here and we're talking about it. And I think that what's really powerful is the fact that, whether it's Janet or Sumit or, Dr. Sinclair or Care Radio or any of the other people sort of watching and joining this, is that we all have the opportunity to choose to make a difference, whether it's talking to a patient, connecting with other physicians, other clinicians, anything on a daily basis. And to me, that's the really cool aspect, is that at 8:00 Central on a Monday night, I can connect with all of you and we can have a conversation like this. And then it sort of lives on forever, that other people can connect with it. So I'm very excited about it. I think it's awesome to have such a young, vibrant physician as yourself to really sort of help lead this change as well. And Janet, the same thing with you. I think
the young, vibrant podcast. Okay, well, maybe part of that's true.
Young, vibrant podcast.
Youth isn't a number.
Exactly right. Everything's
state of
relative.
mind. I just play younger on camera.
That's right. Well, if you blow the light out,
So with that being said, it's kind of coming to the top of the hour. And I just wanted to give Janet, I'll start with you. If there's anything that you want as closing comment or thoughts, and then Sumit, we'll move to you afterwards.
I have to say that one of the challenges with patient experience is that everyone's experience is different, but also in the same situation, everybody's tolerance level, everybody's pain level is different. So even when you have a system that's set up to be a little bit adjustable, there are still so many variations in how people are experiencing this situation that it does seem like is it Scythian task? I can spell it, but I can't say it. But it's just a huge challenge of trying to figure out how to do personalized and individualized medicine when we are all so incredibly individual.
Yep, great point. Sumit?
I think more conversation like this is crucial. I think we need the people that have the patient experience, so patients and their advocates, the people that work to design these facilities like you, Andy, and AJ, and then people who have experience with so much like Janet that are involved in podcasting and getting messages out and communicating in the way that we communicate now, and nurses and doctors and PAs and nurse practitioners. We all really need to work together. And I think that's going to be when that really takes hold in the masses. I think that's when we're going to have that big kind of exciting movement. And I think it's happening. I think that it's definitely there. I am fortunately involved in it. I'm trying to, as every day, I'm trying to get more and more people involved. I try and share my experiences with other physicians, other trainees like myself. They have their concerns with this, but I think the more we discuss, the more we come together in different venues, like a Blab, for example. I never thought that I would be doing this on a Monday night. I just never thought that I would be able to discuss all of these issues that I think are so important that don't get discussed. I think that's what's going to really, help us all work together for that change. Healthcare is a team sport. I've been taught that since I started medical school. And it's great in a clinical sense because when I'm taking care of a sick patient in the emergency department, nurses, myself, the supervising doctors, technicians in the emergency department, we all have a role. We all contribute to that patient's care. When someone comes in cardiac arrest or after a bad accident and have injuries and are very critically ill, we're very good now. We're getting pretty much everywhere. We're getting very good at working together to take care of that person in that moment. I think what we need to do is now expand and not just be good at that, saving that person's life in that moment and being really knowledgeable about what's going to save their life, but after they are done, after they are recovering, how are we going to help them connect to resources to help their recovery? How are we going to get them contributing back to society? How are we going to prevent them from being in that accident? And then while they're being cared for, how are we going to, make their experience better? These are all important, relevant questions that I don't really feel were ever discussed or really emphasized in any of my training. And that's why I'm here. So I think this is amazing. I just want to tell you, Andy, it's an honor and a privilege to be here. You guys are so kind and generous and give me time to talk and all that. I'm just an ordinary person who just happens to do this for a living. And I wish more people thought that way about doctors. I wish more doctors thought that way. And I wish that's how doctors were part of society, because that's just who we are. We work to take care of people for a living, but at the end of the day, we're just like everyone else, and we care about these same things. And so anyway, that's a little bit of what's on my mind.
Well, thank you very much. In closing, I want to thank Janet for hopping in and joining us. Sumit, I want to really thank you for sharing your insight, sharing part of who you are with all of us. It's been an honor for me. It also, gives me this great joy that you and I have been able to connect via the Blab, so beyond Twitter. And, for me, it's really about the connection. It's about connecting the various points. And it's really about resonating that at the end of the day, we're all people and we all want to make a connection. We all want relationships. And if we all work together, we can truly transform this by putting the me back into medicine and giving everyone the ability to choose, what is their ideal patient experience and scaling that at the N of 1. So thank you very much for your time. We're definitely going to have to set up some follow-ups, and I think it would be really cool to have you and your dad on. So yes. So thank you. So with that, I'm going to end the blab. Hey, Janet. It's Andy DeLeo, better known as Cancer Geek in the Twitterverse. I just wanted to wish you and Get Social Health podcast congratulations on 100th episode. I think that's awesome. You've been an inspiration to me. You're part of the reason why I decided to try doing a blab and a podcast. So thank you for connecting the dots. Thank you for being an amazing person. And thank you for caring enough to connect not only myself, but the rest of humanity with important topics and issues and people inside of healthcare that are really trying to put the me back into medicine. So thank you, congratulations, and I'm looking forward to at least another 100 plus more.